Hi guys, welcome back to Coffee Talk. We are on season 2, episode 2, and as promised, we wanted to revisit an episode we had done last season, which was actually 4 years ago. Very long time. We've actually treated quite a few patients since then, so we wanted to update some stats and treatment recommendations in regards to the treatment of catatonia and the ASD and the Down syndrome population. So if you're autistic, you have a 12 to 18% chance of having a catatonic experience. If you're Downs, it's 8 to 10%. And at the time that we filmed 4 years ago, the ASD population was 1 in 54, now we're 1 in 31, and I'm feeling like that's even more significant and more needing to be discussed. So, Mike, I really think we should look at describing what catatonia is again and why it's so difficult, or why is it so underdiagnosed in this population that we work with, and how can we, better support these families?
Sure. Yeah. Again, when I re-looked at our video from 4 years ago, we were talking about it, we had a couple cases, we were seeing more and more. I feel like we have a very specialized psychiatric practice. So we see folks
Niche.
with severe, profound autism, severe developmental disabilities, often hospitalized, often with medical and psychiatric comorbidities. So we have a little bit of a bias of what population we see. But I feel like I consult on someone with catatonia 2 or 3 times a month now.
Yeah.
And so I definitely warranted. So just real quick, you can go back and review the first video, and it has a lot of information, but just for people who may not have the time for that, catatonia is typically described traditionally in the psychiatric population. Back in the day, people with psychosis. And again, antipsychotic medications only started in the 50s. So prior to that, there was no treatment for schizophrenia. There's no treatment for mania. And so people would often end up having catatonia, where very often they wouldn't move at all. You could take their arms and put it up, and their arm would stay there, something we call waxy flexibility. Clanging echolalia, you say something, they say something right back to you. And then there was an agitated version of that where people just moved nonstop and often died from it because they burnt through all of their energy and reserves, and so it was potentially fatal. With the treatment with antipsychotics and other treatments, the rates of catatonia in the general population went down significantly. However, as you've already noted, it is very common in people with autism, and also with people with Down syndrome, and often presents slightly different. It can present typically as I just described, but often it's a regression in many areas. ADLs are lost. So people used to be able to brush their teeth or toilet with no assistance or some assistance, and now that's gone. Very often, eating, drinking goes down significantly, and families will say, well, he'll eat, but I have to take a spoon and put it in his mouth and remind him to chew, and it takes us hours to get him to consume the same amount of food. So you see a lot of delays in being able to initiate and complete tasks, a lot of, again, loss of developmental milestones that were there before. And when you start seeing that picture, you want to at least think about, could it be catatonia? Because it is very treatable, but only if you diagnose it. So it's not particularly difficult to diagnose, but it's very much underdiagnosed. There are scales. There's something called the Bush-Francis scale. It's a catatonia scale, and it's like a check-off list. If you Google Bush-Francis scale and catatonia, a free one will pop up. There's a child version of that that's changed a little bit. However, when you apply that to a population of people with autism, some of those things that would be yeses on that scale that you would say, okay, this is a positive symptom of, occur in many people with autism who don't have catatonia. So scripting, movements, other things like that. And I should say, when movements, there's a whole school of thought that increased rhythmic self-injurious behaviors can be a sign of catatonia as well. So things that we see in this population a lot. So you have to kind of get a baseline. You have to say, okay, before these symptoms emerged, what would have their Bush-Francis scale
Yeah.
score been, like
Yeah.
at baseline. Because you and I would be 0 or 1 or something like that. But someone on the spectrum might be 10, 11, 12 at baseline. And then measure, okay, now where are they now? Because our goal is to get them back to their baseline, not back to 0. Because again, a lot of the things that will be positive check marks on that scale occur in people with autism who don't have catatonia. So it's
Sure.
a little tricky there.
Yeah. Yeah.
But if you're not thinking of it, if you're not aware it's happening, then you're not going to even consider it as a diagnosis. And again, a very treatable condition, particularly if you catch it early.
Yes. Yes. And I think it's just important because there is such a high prevalence that nobody really seeks it out. But 4 years ago when we did the video, I know the golden treatments were either ECT or doing an Ativan challenge. But it seems like things are evolving, and I wanted to kind of chat about what methods now are more preferable, what is more, effective or preferred.
Yeah, sure. So the first thing we do with catatonia, particularly in a neurotypical population and also in a population with autism or Downs, is treat the underlying condition. So very often, catatonia classically occurs in the presence of a major depressive episode, psychosis, and so you're treating the underlying condition. Should be noted that gets tricky because sometimes antipsychotics themselves can push someone into a catatonic state. So it's a bit of an art form there. Very often, people with developmental disabilities or other neurological problems, you don't necessarily get the depression or the psychosis. You just get the catatonia. So one of the ways it's diagnosed, other than just doing scale ratings, is something called the lorazepam or Ativan challenge, right?
Yeah.
Someone appears catatonic, you give them a couple milligrams of Ativan. Very often you have to do it by injection because many of the people who are catatonic aren't eating or drinking, which is what brings us to see that. And in a neurotypical population, you very quickly will see if it works. 30, 45 minutes, an hour, vast improvement.
They wake up.
They literally wake up and start drinking. It's almost like a magic trick when you do it in the hospital. If that works, then you often will then put them on that same medication 3 or 4 times a day, and the doses are high doses, very typically. In a neurotypical population who has catatonia, they're not that high. A couple milligrams of Ativan, a couple times a day is usually where you kind of end up. In a developmentally disabled population, particularly autism, the doses are very high. Average dose 18, 20 milligrams a day. If you tell a general practitioner, a psychiatrist who doesn't specialize in this, that we're going to give someone 24 milligrams of Ativan a day, they'll look at you like you are crazy because
that's scary.
It's
a lot of medication.
Huge dose. It's a huge dose, particularly if you're doing it in the outpatient world. There's all kinds of, in the outpatient world, it's obviously a substance that can be abused. Even if you're not concerned about a patient, it's still a large amount of a controlled substance to have in the household, and you have to be worried about that. If you have people on high doses of Ativan 3 times a day, 10 milligrams 3 times a day as an outpatient, and someone skips 2 doses, there's a very real risk of withdrawal that can be life-threatening. So it's complex, and even just getting insurances and other people to understand that this is how you treat it. In the OPWDD world in New York State, human rights committees that have to approve certain things, you're trying to get a committee to approve a very high dose of a medication for a condition that they're often not familiar with. Yeah. So there's barriers and challenges to doing that.
For sure.
The other treatment, and probably gold standard, is ECT or electroconvulsive therapy. Electroconvulsive therapy can be very successful. There's a big stigma to it, but that's getting better, I suppose. But the issue with ECT is you are under general anesthesia for a little bit of time. So this is occurring either in an outpatient practice where they have the ability to do anesthesia, and there are many psychiatric and neurological practices that can do that, or you're doing it in a hospital. Either way, you need someone who can do the anesthesia, who's familiar with catatonia, because very often our individuals that we work with are not able to give consent themselves. Mm-hmm. And just because you're someone's parent or guardian doesn't mean you're going to convince a physician to do something that is against someone's will,
Right.
Particularly if they're not familiar with it. And so doing ECT, I mean, I'm an associate medical director of a major hospital in the Buffalo, New York area that has a large psychiatric service. It's not particularly easy for me to arrange ECT with someone with profound autism at my hospital. We can do it, but it's not particularly easy. And that's with having some authority in the building and having familiarity with all the physicians. In other areas, certainly big metropolitan areas with universities, easier than in more rural areas, but in many rural areas, there's not ECT at all, let alone for someone with autism. So it's a great treatment option if you can get it done, but it's not necessarily easy to do. So that brings us to the whole conversation about Ambien. Ambien, it's a medication for sleep. It's similar to Ativan, hits the same receptors in a different way, and is used for sleep very commonly. And 4 years ago, if you had said, can you use Ambien to treat catatonia, you would have found a few references, very little in the US or European literature, more in medical literature in India, for instance, about an Ambien challenge. So you give someone 10 milligrams of Ambien, and if it breaks their catatonic state, then you could put them on it like 10 milligrams 3 times a day, something like that. But in the US, when you try to get that approved by people, there really wasn't much research or literature, just some case studies. As recently as last month, there's a new article, just a review article looking at all the case studies, but demonstrating in the case studies were well written and met the criteria for this article, that about 80% of people treated with Ambien got better. There are no head-to-head studies, so I can't say that's better than Ativan or lorazepam, that's better than ECT, because there's no comparative studies there.
Yeah.
But the thing about Ambien is it's a little bit more approachable. If I give you 2 milligrams of Ativan and you get better, okay, now I'm going to put you on 2 milligrams 3 times a day. I'm going to keep increasing that until you get significant improvement, and then we have all the challenges I just talked about. If I put you on 10 milligrams of Ambien and you get better, I'm just going to put you on 10 milligrams of Ambien 3 times a day. Primary care doctors, general psychiatrists are much, more comfortable. I mean, the pharmacist is going to have a question when someone comes in with a prescription for Ambien 3 times a day, because typically it would just be 10 milligrams at bedtime.
Yeah.
But it's a little bit more approachable, a little bit less concerned about withdrawal. Still don't really know what happens when you have someone on 30 milligrams of Ambien for 6 months. You still have to taper it. It's a little bit challenging tapering it because it comes as like a 10 and a 5, whereas Ativan you can break down into like quarter milligrams if you want to.
Sure.
But it's almost come to the point that it's been both in a hospital and outside of a hospital my first line treatment now, because I've seen just robust effects. Again, this is not research, this is just my clinical work. And I've been able to get it through human rights committees that have to approve medication regimens for people in group homes easier than the higher doses of the Ativan. So it's something, and if you walk into a room with 100 psychiatrists and say to them, who don't work in the field of profound autism, for instance, and say to them, what do you think the rate of catatonia is in people with autism? I guarantee you they're not going to say 18%, plus or minus depending on what you read.
Sure.
And if you say, can you treat it with Ambien? You're going to get blank stares from 95% of the people in the room. And yet it's a very effective treatment. Then that is, again, in literature overseas, starting to emerge now in our literature. We need more research on it, but it's also a relatively safe medication that we give all the time. So we don't expect there to be a lot of complexities with it or difficulties given it.
Yeah. I was surprised too when we started, reviewing the literature about that, because Ambien does definitely seem a lot more approachable than high doses of Ativan or ECT, especially if, an individual decides at the last minute and the anesthesiologist is like, well, I'm not going to proceed. This person's objecting. So I think it's a nice option. And I mean, it sounds like there's been some astounding results. So I'm glad to hear that. And it was good to update
Yeah, no,
You know,
it's something that's super important. Again, these videos were built for families, but I think they're helpful for clinicians as well. And again, in medicine we talk about common things being common. If you hear hoofbeats, look for a horse, not a zebra, because horses are way more common than zebras, right? And I think people think about catatonia as like this outlier, when in fact about 1 in 5 people with autism will experience it. And as you note, we're now talking about 1 in 31 individuals.
Yeah.
So when you start talking about 1 in 5 people, this is not an uncommon condition whatsoever, and
Correct.
one that we need to be aware of, and particularly families and individuals with autism, because there are different subcategories of autism that may be more prone to catatonia, but it goes across the entire spectrum.
Yeah, for sure.
Regardless of IQ. So definitely something for people who are able to self-advocate for themselves should be aware of as well.
Yeah.
So
I agree. So, yeah, I'm glad we were able to kind of update the stats and treatment options for everyone. So, if you have any questions or concerns, please drop a line, talk to your providers, or reach out to APIC. That's what we do. Till next time,
APEC out.
APIC out.